the Right Honourable Lady described what a junior doctor is, and I think that was really important, because many people think a junior doctor is just those first couple of years, and isn't it character forming to work a bit hard and not have a lot of money. But in the NHS, which is quite a hierarchical beast, you're a junior doctor all the way until you're not a junior doctor when you become a senior doctor. Either a consultant, as I was for the last 19 years, or a GP. That means you're talking about people who may be in their 30s, they have children, families, mortgages. This is not youngsters who are just able to move around flexibly or have very little financial commitments. And it's important that we remember this. Now, obviously, it's quite some time since I started as a junior doctor. More than 30 years ago, in 1982, when we had absolutely no limits on hours. My light week was 57 hours a week. My heavy week was 132 hours a week. You just had no idea what your name was by the end of a weekend. Now, it took more than 10 years of my career before we got the first New Deal starting to come in the early 90s. And that introduced that trusts or hospitals had to pay an additional premium to junior staff if they worked excessive hours. Now, the definition of excessive hours at that time was still pretty lax, but it was the first step, and it was then tightened up in 2003 when the European Working Time Directive came in. Now, the Secretary of State talks about taking away those safeguards, but that he will replace them with something else. But with what? They have served us well, and when trusts are in financial difficulties, the pressure for them to save money is likely to completely outweigh any little safeguard. The 48 hours working time directive does not come with punitive safeguards, and the financial one was important. It's important to remember that the basic pay is already 7 o'clock in the morning till 7 at night. That's a pretty long day for most people, Monday to Friday. It's proposed that this would extend basic rate of pay from 7 in the morning till 10 at night, and including Saturday. What many people don't know is a junior doctor starts at under £23,000 a year. So below what we've been arguing about the benefit cap. Their salary is largely made up of out of hours.
I thank the Honourable Lady for giving way. Would you not agree with me that in any other walk of life that would be intolerable, and yet we've put up with this situation of National Health Service? And secondly, would you not agree with me that we still haven't seen the $8 billion the government promised during the general election to put in the National Health Service?
Yeah. Well, I would totally agree with that. But as has been mentioned from both sides of the House, people actually do not go into working in a hospital in the NHS to make a lot of money. On the scale of ways for the smartest people in our country to make money, it is not actually that high up the list. They do have a vocation, but we therefore have a responsibility not to exploit them. The Secretary of State talks about that no one will lose money. But I would like to know what will happen to the people who start next August. In the very first change in hours, I went to start my surgical career in Belfast. And what my rota there was, which is a 2 and 3, so every third evening off, no weekends off for a year, was now illegal. It was simply defined by the hospital as your extra hours will be considered as voluntary service. It's a hierarchical organisation. Bullying exists within it. The junior doctor is in a weak position. And these safeguards have worked very well for a very long time. And I would be very reluctant to see them go.
The Honourable Lady for giving way. Would she agree with me that there's a huge sense of loss of morale within the National Health Service? Across the piece, nurses, doctors, everybody, it's down to us to really stand up for the workforce and really make sure that they're at the heart of our thoughts here, not just how it might look politically.
I would totally agree with that. I would agree with the Secretary of State from the point of view of patient safety. There's no one in the profession that does not want to see a 7-day emergency service that is strong and responsive to the needs of patients who are unwell. But we keep moving from the track of people who are ill to routine services. The Secretary of State said we must not call them avoidable, and yet within the Secretary of State's speech we heard 200 avoidable deaths a week. It's exactly the same thing which Bruce Keogh describes as rash and misleading, and people object to that. There are no excess deaths at the weekend. It is from people who are admitted it is the weekend. And that is radiology and investigation. In Scotland, we've been moving to that. We've been moving to that over the last decade. Why? Working with the profession, not pulling out the pin and throwing a grenade. I give way to the secretary.
Can I just make the point, for the sake of clarity, that the 200 avoidable deaths I talked about every week are not about the weekend effect specifically. They're from the Hogan and Black analysis that says that 3.6% of hospital deaths in England have a 50% or more greater chance of being avoidable. That is separate to the weekend effect, where we have these higher mortality rates of people being admitted to weekends. But it is nonetheless, the point I'm making is that where there is avoidable death, where it looks like death rates are higher than they should be, then we have an obligation to do something about it.
I would totally agree that with the Secretary of State that there is an importance of investigating it. But it's also important to understand what the cause of the problem is. A lot of the problem in mid-staffs was the proportion or ratio of registered nurses to patients. That has also been echoed by Bray in his review of 103 stroke units. 103 stroke units, and showed that having additional consultant ward rounds at weekends had no impact on deaths, and yet a better ratio of registered nurses reduced deaths by a third. We need to know what the problem is before we spend billions trying to solve the wrong thing.
I think it would be great for busting this myth about the deaths at weekends. That these may be very sick people admitted at weekends who die within the next 30 days. Look at the number of people who actually die per day in hospitals. It's fewer on Saturdays and Sundays than it is on other days of the week. And the Secretary of State is not giving the right impression of those figures.
I would agree with that, but there's no question that I have also heard since I've come to this place stories of people not being able to access diagnostic imaging, not being able to work up patients. But there is no argument on that from the profession. But that's what we need to focus on, whereas a lot of this seems to be about routine. The reason there are fewer doctors at the weekend is because we don't do routine work. We have a whole teams of people who are doing toenail clinics or blood pressure clinics during the week. If we're talking about doing them at the weekend, Professor Jane Dacre estimates we would need a 40% increase in doctors. We can't do that. What we need to make sure is that the weekend has enough people and the right people to be secure. But junior doctors are already there. It's not them that are missing. And emergency services already have a consultant on call. Now, it may well be that there has to be more discussion about them being physically in, but that is a discussion with the profession, not what we heard on the 16th of July, giving the public the impression that senior doctors only work 9 to 5 Monday to Friday. That was very hurtful to the entire profession.
I'm grateful to the Honourable Lady for giving way, and she's making some extremely powerful and relevant arguments. I just would like to put a point in relation to the importance of junior doctors in my region, and having spoken to some of them at a demonstration on Saturday, they're absolutely essential to the functioning of the service. They have the option not only to go to the Antipodes, but to go to Scotland, where these contracts don't apply. So it will hurt my region more potentially if we lose these valued staff.
Well, like I say, we'll roll out a red carpet somewhere on the M74 and welcome them with open arms. But the progression and migration in Scotland towards robust 7-day emergency care, as I say, has been happening through a dialogue, not through a threat to impose a contract. There are other things in this. The plan to change pay progression, which currently is on an annual basis, to recognise experience. This will be replaced with just 6 pay grades. Now, this is going to affect women particularly, because they tend to take a career break, they tend to work part-time, they're going to get stuck at a frozen level for much longer. It may be a disincentive to people to go and do research because they will be stuck at the same rung of the ladder for longer. We do not want that disincentive. We need to make sure that we are valuing how people develop and the experience that they accrue along the way.
Making a powerful case for dialogue, I wonder if she will either join the Secretary of State and call for the BMA to come back to the negotiating table, or join the Shadow Secretary of State and refuse to call for the BMA to come back to the negotiating table. Which will she do?
I think that there is no question. excuse me, I think there is no question that we require dialogue, but it must be sitting down at a table without preconditions, because what happened in July and through the summer was the threat of imposing a contract instead of proper negotiation. And that's where we should be trying to get to, that both sides negotiate in good faith across a blank sheet of paper. It's the threat of imposition that is what has hurt the junior doctors. Now, it has also been talked about taking away the guaranteed income protection of GP trainees to try and keep them at the same level as they were and replace this with a discretionary payment. Now, a discretionary payment can be taken away at any time, can be cut, can be changed. The Secretary of State aspires to have 5,000 extra GPs by 2020. We know from the BMA service that 1/3 of GPs, that's 10,000 out of just over 30,000, are planning to leave. That means we need to find 15,000 extra GPs. So anything that is a disincentive for people to go into that profession is not serving the NHS. Sorry.
Thank you, Honourable Member, for giving away. Do you think the Secretary of State is an incentive or a disincentive to junior doctors?
Sorry, I didn't hear.
Thank you, Mr. Thank you to Mr. Deputy Speaker. They don't want me to repeat the question on that side of the House, but do you think that the Secretary of State is an incentive or a disincentive to doctors?
I think how it's been handled is a total disincentive, but I think that could change. We could simply make the decision going forward to move to negotiations without preconditions, without threat of imposition. To threat to impose, to change terms and conditions for people who in the past, like me, routinely worked over 100 hours. That is a ghost that haunts the NHS, and it's something that really frightens junior doctors. Okay, the last time I need to make progress, or no one else gets to speak.
Huge amount of respect for her. She talks about working long hours from her experience. In relation to what the Secretary of State has just said about introducing new limits on junior doctors' working hours, does she think from her own experience that this is the right way forward, which wasn't that before, but what he's just said now is the right way forward?
Well, what the Secretary of State hasn't explained is how within the same pay envelope there will be more people at weekends but not working extra hours but not having less during the week. So at the moment it is a circle that can't be squared. So I think we need to see the detail of how that can be done. If the vision is actually having more routine work at the weekend, as I say, that would be a massive uplift in numbers of doctors that we just simply can't afford. Now, we are already hemorrhaging doctors. Acute physicians describe 48% of junior places unfilled. Obstetrics is 25%. They can go anywhere. And we heard that over 1,500 of them registered for certification for overseas work just last week. We need to be careful that we are attracting them to stay. They are the brightest and best in our society. They have chosen to do a vocation. We need to bring them to the table, but by offering to start with a blank sheet of paper, not threatening them. They are not radicals, as was said. They are people who want to do their best for their patients. So I would suggest that the Secretary of State and those who are working with him look at how they have spoken both to senior and junior doctors over this summer, which frankly, having come new to this House, I found was quite shocking and quite disgraceful. I think we should draw a line under that and try and change the tone and try and go forward and find a solution that is fair to junior doctors, fair to patients and safe, and is not exploiting people and not by threatening people. Thank you.